Buprenorphine with or without naloxone has become a widely utilized medication for opioid use disorder. Previously called medication-assisted therapy, preferred language now refers to this as medication for opioid use disorder, or MOUD. Buprenorphine with naloxone is available as a sublingual film and 2 different formulations of a sublingual tablet. Additionally, buprenorphine alone is available for the treatment of opioid use disorder as a monotherapy sublingual tablet, a subcutaneous implant, and a subcutaneous solution for injection. There are many misperceptions surrounding buprenorphine products for the treatment of opioid use disorder. Myth number 1. Persons using opioid replacement products for opioid use disorder aren't really in recovery. Unfortunately, this belief continues to permeate throughout healthcare, despite numerous studies demonstrating the ability of persons stable on these medications to resume fulfilling, productive, and healthy lives. Myth number 2. Buprenorphine products are overprescribed and can be misused. Buprenorphine should be considered a life-saving drug that aids in preventing return to use or relapse. Additionally, given its pharmacology, buprenorphine may be considered protective against overdose during instances of return to use. While buprenorphine can be misused, most persons who use opioids report using non-prescribed buprenorphine to assist with stopping other pure agonist opioids. Either due to stigma or finances, access to legitimately prescribed buprenorphine as a medication for opioid use disorder treatment continues to be suboptimal. Myth number 3. Overdose with buprenorphine happens as frequently as other opioids. This is false. There is a ceiling effect for this drug for both analgesia as well as adverse effects, including respiratory depression. Overdose is possible, although this is more likely when buprenorphine is taken concurrently with other non-opioid respiratory depressant drugs, like benzodiazepines. Myth number 4. Using buprenorphine without getting therapy doesn't count as treatment for opioid use disorder. While combining pharmacologic and non-pharmacologic treatments is preferred, studies suggest that persons can enter long-term recovery using buprenorphine-containing products as monotherapy without co-occurring psychotherapy. Additionally, other data suggests some persons are unable to continue in buprenorphine treatment programs due to overly burdensome counseling requirements. A significant shift in the philosophy of opioid use disorder treatment has emerged, with buprenorphine being viewed as part of harm reduction efforts. Myth number 5. Buprenorphine should only be used for a short period of time to help with opioid detoxification. Buprenorphine-containing products do significantly help with reducing intolerable symptoms of acute opioid withdrawal. However, return to use and relapse largely follows triggers and cravings, both of which long-term buprenorphine can help attenuate. Weaning of buprenorphine when being used for opioid use disorder should be a shared decision between patient and prescriber. Buprenorphine, while not a one-size-fits-all approach to opioid use disorder, is a valuable tool to offer persons seeking treatment for this disease. Patients should be educated about potential long-term adverse effects of buprenorphine, including dependence, constipation, hypogonadism, tolerance, and dental-related disease. Information about Suboxone and opioid use disorder treatments, as well as other helpful resources, are available at www.ilpmp.org. This prescribing tip is brought to you by the Southern Illinois University Edwardsville School of Pharmacy and the Illinois Prescription Monitoring Program.